This is a video in clinical medicine from the New England Journal of Medicine.
The first successful public demonstration of the inhalational induction of anesthesia took place in the surgical amphitheater of Massachusetts General Hospital on October 16, 1846. The occasion, which is considered to be one of the most important events in the history of medicine, was commemorated in 1868 with the installation of the Ether Monument in the Boston Public Garden. Today, inducing general anesthesia through the inhalation of anesthetic gases remains an important technique in a variety of situations. This video demonstrates the induction of general anesthesia in pediatric and adult patients through the administration of sevoflurane and the use of the circle breathing system. Particular aspects of the technique may vary depending on institutional guidelines, the available equipment, and the manufacturer's instructions. Inhaled anesthetics should only be administered in adequately equipped environments by qualified clinicians who are experienced in managing the care of patients under general anesthesia. Inhalational induction is indicated most often in children in whom the placement of an intravenous catheter while they are awake would be painful or distressing, in adults in whom it is difficult to obtain intravenous access, and in patients who have intellectual or developmental disabilities or needle phobia. Inhalational induction is also used in patients in whom the ablation of spontaneous respirations may be detrimental, such as those with anterior mediastinal masses who may be at risk for airway or cardiovascular compression. However, the use of inhalational induction in managing difficult airways while maintaining spontaneous respirations has declined owing to technological advances such as video laryngoscopy. Pharmacologic innovations such as the development of propofol and dexmedetomidine, as well as the ability to rapidly reverse the effects of neuromuscular blocking agents with sugammadex, have also decreased the popularity of inhalational induction. Intravenous induction of general anesthesia is generally the preferred means of inducing anesthesia. It is faster and is associated with fewer complications than inhalational induction. Inhalational induction is contraindicated in patients who are susceptible to malignant hyperthermia. Relative contraindications include hemodynamic instability and intracranial hypertension. Caution is also required in patients known to be at risk for aspiration. Commonly used potent inhaled anesthetics, such as sevoflurane, are non-ionized halogenated ethers with low molecular weight that cross semi-permeable membranes easily by means of simple diffusion. Nitrous oxide, another inhaled anesthetic, is an inorganic compound with low potency that can be used as an adjunct to more potent agents. The uptake of inhaled anesthetics is a passive process. The speed of uptake is determined by the solubility of the gas, the alveolar concentration gradient, and the area and thickness of the alveolar membrane. This graph shows the process of anesthetic uptake by presenting the ratio of the fractional alveolar concentration of anesthetic, Fa, to the fractional concentration of inspired anesthetic, Fi, over time. The rate of increase in the ratio of Fa to Fi is determined by the amount of the anesthetic that is delivered to the lungs and the amount that is removed from the lungs by the blood. Thus, during induction, the lower the solubility of the inhaled anesthetic, the faster the rise in alveolar concentration. Once the inflection point of the curve has been reached, the rate at which the anesthetic is removed from the lungs slows down, and the ratio of Fa to Fi progressively approaches a value of 1. Infants and children have a more rapid rise in the Fa to Fi ratio than adults. This difference is attributed to a greater ratio of alveolar ventilation to functional residual capacity in infants and children than in adults, among other factors. A common means of expediting the induction of anesthesia with inhaled anesthetics is to administer a concentration of anesthetic that is higher than the desired target alveolar concentration. Anesthetic gases pass from the lungs across the alveolar capillary membrane into the systemic circulation. Arterial blood delivers the anesthetic rapidly to highly perfused organs such as the brain. Over time, the anesthetic concentration also rises in muscle, fat, and other poorly perfused tissues. In the United States, the anesthetic agent that is most commonly used for inhalational induction is sevoflurane. Desflurane and isoflurane are poorly tolerated because of their pungency, and nitrous oxide is not potent enough to be used alone for inhalational induction. Interview the patient and the guardian, if the patient has a guardian. Explain the procedure and describe the sensations the patient may experience during the induction, such as the pungency of the inhalational anesthetic, lightheadedness, and disorientation. If the patient is a child, explain the procedure to the child's parents or guardian. To reduce anxiety in pediatric patients, have toys and games available. The presence of a child life specialist, a healthcare professional who helps children cope with medical procedures, may be helpful, and the presence of a parent or guardian may help the patient follow instructions. When treating children, it may also be useful to introduce the face mask and encourage them to decorate the mask or to apply an aromatic scent. The administration of a pharmacologic anxiolytic such as an oral benzodiazepine may be helpful in patients in whom there is not intravenous access. The use of face masks and other personal protective equipment, PPE, in clinical settings is rapidly changing because of the pandemic and new variants of SARS-CoV-2. Clinicians should follow their institutional guidelines. If premedication is administered, the patient should be monitored for the level of sedation. Transfer the patient to a stretcher and take the patient to the anesthetizing location. Minimize noise and unnecessary conversations. Younger children and patients with intellectual or developmental disabilities may be particularly sensitive to stimuli, including sound and touch. The equipment necessary for inhalational induction includes the following: an anesthesia delivery apparatus with a circle breathing system, physiological monitors, including a non-invasive device for measuring blood pressure, a pulse oximeter, and carbon dioxide and electrocardiographic monitors, suction device, airway management equipment such as a transparent mask, oral and nasal airways, a laryngoscope with appropriate handles and blades, supraglottic airway devices, and endotracheal tubes, emergency medications such as succinylcholine and atropine for intramuscular or intravenous administration, equipment needed for intravenous access, anesthetic medications including induction and neuromuscular blocking agents. Ensure that all equipment is functioning properly and that the selected items are appropriate for the patient's age and size. Placement of the monitors in preparation and throughout induction may trigger agitation in some patients. Position the pulse oximeter first. Position the remaining physiological monitors as soon as the patient can tolerate them. Start the flow of oxygen. Completely open the adjustable pressure limiting valve to make sure that the breathing circuit will offer no resistance to respiration. Tell the patient that you are going to position the mask on the patient's face. Be aware that this may cause anxiety and claustrophobia in the patient. Instruct the patient to breathe normally. Turn on the vaporizer and gradually increase the inhaled concentration of the anesthetic agent. Maintain a good mask seal. Any entrainment of ambient air prolongs induction by diluting the concentration of the anesthetic. With each breath the patient takes, note the fogging on the mask, the rise of the patient's chest, the coloration of the patient's face and lips, and the capnogram. Listen carefully to the rate and tone of the pulse oximeter. Gradually, the patient will lose consciousness. During the administration of the anesthetic, the patient may become restless and may make involuntary movements. If these movements become vigorous, it may be necessary to restrain the patient. The patient may also have irregular respirations, tachycardia, and hypertension during the administration of the anesthetic. Frequently, the patient's arms and legs become rigid, and there is increased tone in the abdominal wall. The patient will also lose the eyelash reflex, and the pupils will become dilated. The gaze may be deviated or disconjugate, and there may be conjunctival injection. Lacrimation may increase. During this period, airway reflexes tend to be hyperactive. Attempting to connect additional monitors or to place an intravenous catheter may trigger laryngospasm. If necessary, support the airway with maneuvers such as the chin lift and jaw thrust maneuver. Consider inserting an oral or nasal airway. The pressure limiting valve can be adjusted to provide positive pressure ventilation if necessary. Observe the movements of the reservoir bag. Palpating or squeezing the bag in synchrony with the patient's inspiratory effort will provide feedback on the patient's respiratory efforts and lung compliance. Be prepared for the possibility of regurgitation of gastric contents and the accumulation of secretions, which will require suctioning of the oral cavity. Continue to increase the concentration of the inhaled anesthetic. Gradually, the patient's respirations should become more regular. The heart rate will slow. The pupils will constrict, and the gaze becomes conjugate, tearing decreases. Once the patient reaches a deeper plane of anesthesia, the muscle tone will decrease. At this time, it should be safe to place any remaining monitors and to attempt intravenous access. Administer additional anesthetic medications and proceed with airway instrumentation and endotracheal intubation if indicated. Once the airway has been secured, adjust the concentration of inhaled anesthetic to a level that is appropriate for the maintenance of anesthesia. An alternative approach in patients who are able to follow instructions is to use single-breath vital capacity induction, in which the patient inhales a high concentration of anesthetic in one breath. Prepare the breathing circuit with 8% sevoflurane in 100% oxygen. Instruct the patient to exhale maximally and then to inhale as deeply as possible directly from the face mask. Tell the patient to hold the breath as long as possible and then breathe normally until unconscious. With either approach, nitrous oxide may be used as an adjunct during induction. Nitrous oxide is not pungent and expedites induction with the potent inhaled anesthetic. Discontinue nitrous oxide before attempting intubation to achieve a higher inspired oxygen concentration. Always ensure that the patient is breathing an adequate oxygen concentration. Continuously monitor hemoglobin oxygen saturation. The complications of inhalational induction of general anesthesia include apnea, airway obstruction, aspiration, laryngospasm, bronchospasm, cardiac dysrhythmias, hemodynamic instability, and cardiovascular collapse. Clinicians must remain alert and prepared to address any of these and other complications at all times. When practiced by trained clinicians, inhalational induction of general anesthesia is a reliable technique in both children and adults. It is important for clinicians to understand the pharmacology, equipment, and approaches to this technique in order to deliver appropriate treatment and avoid complications. Thorough preparation, careful patient selection, and continuous monitoring are required to safely induce general anesthesia by inhalation of potent anesthetic agents.